Welcome to Afya Yetu program. My name is Charity Inyanya, and today I will be talking about pelvic health and laparoscopy. Matters to do with the female sexual health. I'm not alone in studio. I am joined with a doctor, a surgeon. His name is Dr. Albert Ayumba. I'll give him his time to introduce himself so that you may know more about him. Karibu, Dr.
Thank you.
Hey.
Thank you for hosting me. As you said, we are having the Afya session for your viewers.
Yes.
Wherever they're listening or watching us from. My name is Dr. Ayumba. I'm a medical practitioner in the county and in the country. I am a trained consultant obstetrician and gynecologist with keen interest in general obstetrics and gynecology, but also with a subspecialist training in pelvic floor medicine and reconstructive surgery.
Okay.
With also special passion and interest in minimal invasive surgery.
Okay.
As your topic suggests. Thank you for having me.
So when we talk about laparoscopy, because when I introduced this topic to my colleagues here, they were like, "What is that?" Most of us, we don't know what it entails. Yeah.
That's okay. So laparoscopy is one form of minimal invasive surgery. So, but in layman term is keyhole surgery.
Okay. Okay.
So surgery has evolved over time since the practice of medicine has been. We have different techniques of trying to solve medical problems that will need opening up the body, whichever region of the body that you need. And each subspecialty has evolved to adopt methods that cause less disruption.
Okay.
Okay, because surgery is like creating a wound to a person. So we try to cause less injury, less surgical injury when you're trying to sort out any medical problem. This will enable you to recover fast. It will give you less pain after surgery.
Okay.
And especially the cohort of patients that we deal with, that's the women, they also need to have less surgical scars.
Yeah.
Okay, so they need, it's aesthetically appealing when we create minimal scar tissues on their bodies, okay?
Okay.
So anywhere around the abdomen or the pelvis, we just make small keyhole incisions, we put a camera, and we're able to solve the issues that the patient has. That in its own gives you also the power of closer view, because it's a magnification from the camera. And so you're able to do a targeted treatment.
Okay.
Okay, so that is one form. There are many other forms of minimally invasive surgery.
Okay.
Yeah.
So at what point do doctors suggest this procedure in a patient's life?
So yeah, it depends. That's a good point. When a patient is suffering from whatever ailment, we give them options. We can watch over this for a time if it's giving you too much concern, it's affecting your work, your family life, your social life. We can try medication of some sort.
Okay.
If it's not concerning, and watch over it, maybe repeat and come on follow-up for the clinic. But if we explore those options and nothing is giving, then the next remedy will be to give something that will take out the problem or the disease once and for all. Most of the time it's surgery.
Okay.
And then also you find there are some diseases or illnesses that are very concerning from the outset, okay? So we don't want you to wait for long to stay with the disease. Straightforward, we'll advise you to just get rid of that problem, because we might need to further test what is this that is growing inside you, what is this that is ailing, maybe you're bleeding, okay? Something that is acute or risky. then we go straight forward to give you the surgical options. So it varies. It varies on the illness and how much it's disrupting your day-to-day life.
Okay.
Yeah.
So when the incision, when the surgeons are doing the incisions, what exactly are you looking for? Wakati mmeka hiyo camera, you want to see what is inside. What exactly are you looking for?
So before we opt for surgery, we have a discussion based on your symptoms and based on the tests that you have done, preliminary tests, we call them. We can have blood tests, we can have some imaging of sort, for example, an X-ray or an ultrasound or a CT scan or an MRI, which are widely available. But also we perform our own examination and assessment. Okay. For example, commonly if you have tumor of the ovary. Ovary is, I hope you understand. Okay. So if you have tumor of the ovary and it's of big size or is causing a lot of pain, it has a risk of bleeding into itself.
Okay.
It has a risk of rupturing. It also has a risk of twisting on itself. Okay. So the bigger the tumor, the more chance of you going, us opting for surgery. Okay, compared to a smaller lesion. Or if a tumor is very concerning, then we, depending on your age, your family risk, for example. For example, cancers of the ovary are very silent. We catch them when they are late, but these days we are very proactive. We want to catch them early. The other issue, for example, if you have pregnancy that's out of the womb, we call it ectopic pregnancies, commonly on the tube. Okay, so no need to have a big incision, especially the young group of patients. We can just make small incisions and remove the problem. So we go for the target. After our preliminary assessment, then we make a decision on what we are going to do. Okay. These are discussions between the patient and the doctor.
Okay.
Yeah.
Okay. So what are the main causes of this condition?
So it depends. So gynecological problems can either be something that happens very rapidly or something that takes a long time.
Okay.
Okay. There are those ones that will happen when you're in your reproductive years, and there are those ones that can come when it's your later years of life. We call it menopause. All right. So we have conditions that are non-cancerous. Okay. And commonly, I'm sure you've heard about patients saying they have growths on their womb. Okay, we call it fibroids, or they have growths on their ovaries, as we've said, okay, or they have any other growth that's within the pelvis that is neither on the womb or the tube, okay. A growth can come from the abdomen and still occupy your pelvis, or the other way around. But also there is a group of diseases that are cancerous. Okay? Yeah. So each of those organs in the reproductive system of the woman can have a growth that is non-cancerous or a growth that's cancerous.
Okay.
There is also the group of infection. Okay, you can have accumulation of infection in your pelvis if you don't take care of it early.
Okay.
You can have foreign bodies in your pelvis. For example, if you are using the intrauterine device, many patients will call it the copper IUDs. It can be misplaced and enter into your pelvis. You can have foreign medical objects that are left behind. You can retrieve them with laparoscopy.
Okay.
Then of special interest also is, as in my line of sub-training, is if you have any of the organs in your pelvis herniating down through your vagina, all right? The human body was made to contain your organs inside your pelvis.
Yeah.
The pelvis is a bony structure. So with time, there are those risk factors. Maybe if it's part of your discussion, with age and those risk factors, you might find the womb is coming down, the bladder, your urine bladder is coming down, or your rectum is coming down.
Okay.
We're also able to correct that with laparoscopy.
Okay.
Yeah.
So you've mentioned something about infection. And this is something that is really affecting most of us women. So what will be the cause of recurrent infection? You find that, okay, I've treated an infection this month, yes, I've not met with my partner, but it's still recurring. Yes, what will be the reason or the causes of that?
So infection depends on the type of infection, the risk factors, but broadly, your sexual hygiene,
Okay.
your menstrual hygiene, your own personal hygiene. All right. That's if you are saying you have a partner, then it applies to both of you.
Okay.
All right. Those sexual issues are slightly different from what will affect you. So we have sexual transmitted infections
Okay.
and non-sexual transmitted infections. Okay. So they will affect your reproductive tract. Your reproductive tract starts all the way from outside your birth canal to include the area around your anal area, around your birth vagina, if you allow me to use that term, and also around your urine pipe, okay? And any of these infections can ascend into any of those body organs or body channels. So if you're talking about the reproductive tract, it's your birth canal, your cervix, that's the lower part of the womb itself, the tubes, the fertility tubes, the ovaries, and the entire pelvis. So if you don't take care of the infection, it keeps ascending.
Okay.
And at each stage, then you have pain, you have maybe your physiological discharge is now turning into abnormal in terms of color, smell, amount, okay? You find maybe when you're meeting your partner, you're in pain.
Okay.
You find maybe there might be a growth, there might be limitation of your activities, okay? If it ascends in your urine channel, then you have irritative symptoms when you are in your voiding habits. You can void more frequently than normal. You can, when you feel pressed, you need to reach the washroom urgently, okay? Or when you're passing urine, the urine has a burning sensation on your urine pipe, okay? So that is how it presents. So if you feel anything out of the normal, then you need to seek treatment early, because these infections, even in your urine, can ascend all the way to the kidneys, okay? In its worst form. Rarely, but in its worst form, it can ascend, and those are on the severe end, okay? So we always advise ladies or even men, okay? Because also men have the reproductive organ and that is also the urinary organ, okay? So the same thing, burning sensation or bleeding or pain around your testicles, okay? Then you have to seek attention early.
Okay.
So there are those sexually transmitted infections that we have to contact trace your sexual partners.
Okay.
Whether it's your husband or your fiancé, or whatever it is, boyfriend or your girlfriend, then you have to trace them down and also test them or put them on treatment.
So both of them have to go
Yes.
to undergo treatment.
Yes.
Okay.
But those that are non-sexual, then we advise you on how to take care of yourself. We put you on some treatment. All right. But also, if you're having this kind of frequent issues, please don't forget the hue and cry also is about screening yourself for early changes in your reproductive tract, and you all know about the big topic of cervical cancer.
Yeah.
All right. So if you are sexually active, you are over the age of 24 in our country, then you should present yourself for routine screening. Don't assume it's just an infection. Let your doctor examine you and recommend what is supposed to be done.
Okay.
Yeah.
Now this myth, I don't know if it's myth, people always say that if you have these recurrent infections, chances of you being infertile are very high. Is this true?
It's not a myth. It has some biological plausibility.
Okay.
Right? Because as I explained, if you don't take care of infection early enough, then it ascends up your reproductive tract. Right? And your reproductive tract has specific functions for you to be able to conceive and carry a baby. Right? So the infection, if it is very severe, then it will harm your reproductive system.
Okay.
All right? It will cause inflammation and scarring of your womb and your tubes, and sometimes your ovaries also. Okay? So especially your tubes, they are delicate and functional organs. So your tubes, for the listeners and viewers, is where the sperm and the ovary, or the woman's egg and the man's gamete will meet for fertilization. It happens in the tubes, all right? And if then it's affected, if you don't take care of it, and it's destroyed by the infection and the healing causes the tubes to stick together, then the communication between the woman's egg and the sperm is cut off.
Okay.
So that's a common phenomenon. It's not really a myth. The message is treat your infections early.
Okay.
Okay. So the tube can block anywhere close to the womb or further from the womb. It depends on how it blocks.
Okay.
And when your tube blocks, your conception chance is reduced. Okay. The best option you have is to go for assisted reproductive technique. But most of our clientele, most of our folks cannot afford that.
Okay.
So there are selected patients that we try to see if we can open up the tubes. Okay. We need robust. I mean, whatever scientific evidence is there is that it doesn't really work as much. But in this part of the world, that is sometimes the option that the woman is left with. All right. Because going for assisted, like for IVF is when we get to assist you and your partner to conceive by passing the fallopian tube.
Okay.
You might find one trial when everything is optimum is upwards of 800, average $1 million, Bob. So not everyone is able to afford that. So sometimes we can discuss and carefully select those ones we can try to see if we can mechanically open the tubes.
Okay.
Of course, as I had mentioned earlier, the tube is a functional organ. It's not just a tube. So if it is damaged, then it depends on how it's damaged. Some will succeed, some may not succeed. Yeah.
Okay. Let's talk about ovarian cysts. Also, it's something that is most common in most women, because I have two of my friends who went through operation and one of the ovary was removed. So what could be the cause of ovarian cysts? Yeah.
So I really, it's very unfortunate. They should not be a doctor that's removing a whole ovary just because of a cyst.
Yeah, two of them actually.
So
they
we don't remove the whole ovary. Because yes, you have two ovaries and you're born with a fixed amount of eggs to release every month. Some will just shed off naturally, but we don't remove the whole ovary. Okay. We, depending on the pre-operative evaluation. So if you see your gynecologist, they're able to use specific risk profiles, depending on your family, your age, and then specific imaging profile. Okay, so if you do your transvaginal ultrasound, it will give some characteristics of that cyst. Okay, and so we're able to decide if it is a high risk or a low risk type of cyst. Okay. So, but we don't, especially, I'm assuming your friends were not very, they were young patients.
30 years and 27.
Okay, so that's young. I may not know the reason why, but we avoid to remove the whole ovary.
Okay, the one, the 30-year-old one, the moment the ovary was removed, she later on conceived, but it was confirmed that she was carrying twins. But one was ectopic pregnancy. Yes.
The same patient or a different
Yeah,
patient?
the same patient.
She had twins and ectopic. Yes,
so she had twins. One was okay, but the other one, the same, but it was ectopic. So they had to take her to theater, remove the ectopic one, and then they left her with the other one.
Okay.
Yeah.
Okay. So that one we call it heterotropic.
Okay.
So you can have a baby developing inside your womb, and then another baby outside the womb. Okay. So we have to preserve the one inside the womb and take out the one outside.
Could it be the effects of these ovarian cysts because the ovary was removed? Yes.
The other pregnancy was in the ovary, or why was the ovary removed?
She went in for ovarian cyst, and then the ovary was removed. Later on, she conceived.
Okay.
Yes.
And then she conceived that kind of...
Twins.
Don't call it twins. Twins means two gestational sacs or two babies growing in the womb.
Yeah,
Can
okay.
be 2, they can be 3, they can be 5, they can be 6. But if one is inside the womb and one is outside, it's
Okay.
not a twin pregnancy. Okay? Heterotropic pregnancy.
Okay.
All right? It's sort of a mixture. Okay? But cyst removal, as I said, depends on the risk. So the risk profile and all those assessments. So there are those what we call functional cysts.
Okay.
Women, if we do scans, even here in the studio, we'll find 1 or 2 ladies as a cyst, because your ovary is a hormonally active organ, responding to hormones and also producing some hormones. So every cycle you're ovulating, so you might find sometimes the egg is not bursting out fully from the ovary. It might have some fluid there and it's a cyst.
Okay.
So we don't remove every cyst. But even if we need to remove the cyst, we don't remove the whole ovary, because you need that ovary for your fertility.
Okay.
So it's not good to remove the ovary. Anytime you are having this kind of issue, please be sure that your doctor is not removing your ovary. So there are those ones we will remove the ovary. If there is a risk, if there is a high risk that this is a malignancy, before the assessment or intraoperatively, but the doctor will expressly counsel you that this is the case, we might remove your ovary or not. Okay? But I'd not advocate for removing someone's ovary, because you're messing up with their fertility potential.
Yes.
The thing about the causative factors, so sometimes it's just your individual risks, but I'd say commonly here, if, for example, we have these hormonally active contraceptives, okay?
Okay.
Like the injectables. Some clients use a lot of the injectables or the implants. They can give you small cysts, ovarian cysts, okay?
Oh, okay.
Depending on the discomfort and everything, it hardly goes to surgical proportions.
Okay.
But we can follow that up. That's one of the issues. The other issue I'd like to say is, if you've heard of a lot of women going through menstrual pain, pelvic pain, pain when you're there with your partner, sometimes pain when you're passing, we're going for long haul. You've heard about endometriosis?
Yes.
All right? So sometimes you can have that accumulation of the menstrual fluid in your ovary. So it can give you an endometrioma, okay?
Okay.
So that one we might need to take it out, because it's reducing your ovarian fertility and it's causing that discomfort every month, okay? Pretty much that is it.
Okay.
In terms of ovarian cysts.
Okay.
So there are different types of cysts. Even in pregnancy, you can have a cyst.
Okay.
And that cyst in the first 2 months or so is supporting your pregnancy.
Okay.
So your doctor should not remove that cyst when it's supporting your pregnancy.
Okay.
Right? That's why I was concerned when you said there's a cyst and the patient, your friend, is pregnant, but you clarified that this was removed before. Okay.
So the other friend was worried that now that she's gone through this procedure, the operation and all that, now she was afraid that maybe in future she might not be able to conceive because she's not a mother. Yeah.
The one that also the ovary was removed.
Yes.
And she was 30-something.
27. 27. Yeah.
Yeah, I can understand why she's concerned, because one of her ovaries has been removed. Okay. Okay. But there's still a chance. She's still young. Okay, so the other egg will be sufficient. I don't know why a whole ovary was removed. She's young, so she still has a chance. I guess with good support she'll conceive. Okay. But I understand her concern, because one of the factories for producing her eggs has been reduced. Yeah. Removed, rather. Yeah.
So you talked about endometriosis.
Endometriosis.
Maybe you can just explain to our viewers what it is and what it entails, and the causes and the effects, and also the signs to watch out for. Yeah.
So what is endometriosis? In simple terms, your womb has a lining inside. So your womb is a muscular organ, but it has a functional lining inside. Okay. Where as you ovulate, the womb is prepared for conception. But if there is no conception, then the lining will shed itself at the end of your cycle as menstrual fluid.
Yeah.
Okay? So there is that activity month in, month out. But sometimes the tissue elements that is supposed to be within the womb lining is found outside the womb.
Okay.
Okay? And wherever those tissue elements are found, they also respond to your hormonal cycle. So if they are found inside your pelvis, or they are found in your ovaries, or they are found sometimes in your lungs, in your brain, or in your large bowel wall, okay? So they will respond to the hormones. So every month, those tissue elements are also being active. And this blood, you know, it's not, if it's out, if it's in those areas, it's kind of an irritant, okay? It's kind of an irritant because it's causing a lot of inflammation. Sometimes if it accumulates enough to also have no space to keep accumulating, of course it's causing pain. Or sometimes if it's next to nerve within your body, then it will cause direct pain. So things to watch out for are the excessive pain during your cycles. Okay, so we no longer advise our clients to just persevere the monthly discomfort.
Okay, not to take it as normal.
Normal, that's the right term. Thank you.
Okay.
Or sometimes, if you are, for example, together with your partner and you feel deep pain, okay, around your deep vaginal area or even in the rectal area, okay, sort of burning pain that can even travel, like it's traveling to your back or towards your lower limbs, okay, or towards the rectal area, okay, that's a bit concerning, all right. Sometimes you may have an obvious growth. As I said, the fluid can accumulate in your ovaries, and the good thing, we can pick that very easily with our ultrasounds, okay? Especially if you do what we call a transvaginal scan or an endoanal scan, okay? Sometimes we may ask you to do an MRI because it can quickly tell us that. But eventually, we need to put this camera inside and identify grossly what we are seeing as to be endometriosis. The other thing is it might also reduce your, your potential to conceive.
Okay. Yeah.
Because it's causing a lot of irritation, a lot of fibrous adhesions in your pelvis. So it might affect the ovum transport through the fallopian tubes, as we discussed. It might reduce the capabilities of your eggs to be produced in good quality and numbers every month through your reproductive years, and so on and so forth.
Okay.
So it's a big thing. The only thing is, don't take pelvic pain as normal. Okay?
Okay.
Of course, there are many other causes of pelvic pain, but endometriosis is also quite common.
And is it treatable?
So yes, we can manage it.
Okay.
We may not fully, depending on the spread and the stage. All right?
Okay.
We can manage it depending on the stage. And so the later stages are a bit difficult, depending also on your fertility desire. There are those ones who have already finished their family size. There are those ones who want to start. So our management options depend on that, because the drugs can suppress your function. So you may not get pregnant when you're on those drugs. The surgery might also further reduce your function, fertility function. Sometimes the surgeries are a bit radical or extensive, if I may say that. So it depends on your fertility desire, the symptoms that you have, and then the stage of the disease. So yes, early stages can be treated. Later stages can be managed.
Okay.
Yeah.
Is it connected with the fibroids?
Not really. Let me say technically yes. How do I say so? Because these tissue elements that are lining the uterine, the womb, can also get into the substance of the uterus. They're not supposed to be within the muscular layer of the womb. They're just supposed to be inside. So if they are also in the muscular layer of the womb, that is endometriosis interna. So yes, and it can coexist frequently with the fibroids. We call it adenomyomatosis. Okay. So yes, to answer your question, it happens like that.
Okay. So let's say a patient has come to you that has fibroids. What is the first procedure or the first stages that the patient is able to go through so that she may acquire the treatment and then go back to her normal life?
So fibroids are quite common in our African race. They're also common in the group of women who take a little longer to get their first child, all right?
Okay.
And those ones who are from a family that, for example, your maternal side or paternal side, they've had fibroids also. So family history of fibroids. And being that we are of black race descent, we are at a higher chance of having fibroids. So you'll find by 40 years, almost 30-40% of women will have uterine fibroids. But it depends on the size of the fibroid. Okay? So the smaller the size, no symptoms, we can watch over it, and depends what you want to achieve in terms of a family size. It depends on the symptoms. That's a second consideration. So a fibroid might be causing you a lot of bleeding,
Okay.
a lot of pain or pressure symptoms. Okay? So you might find you may require us to act fast than give you time to watch or try to conceive or try to carry a pregnancy, because maybe you're losing every time you try. It's also a risk when you're during your delivery that you have big fibroids and so on. So the symptoms, how bad are the fibroids distracting you from your day-to-day activities?
Okay.
The other consideration you make is your family size or your fertility desire. Okay? So if you're 40, you have fibroids, they're multiple, they're moderate, they're causing a bit of moderate symptoms. You've already had your children, we'll treat you differently from when you're young. Okay? So we might want to remove the fibroids only, or we might want to remove the fibroids and the womb. Depends, it's a discussion. Okay? But that is also available. It's also available. We can do it laparoscopically, we can do it open. We can also use ultrasound energy, focused energy to strip the blood supply to those fibroids. Okay? So it depends on the size, the number and location, and your family desire.
Okay.
Family size desire.
Okay.
Yeah.
So you say that it's something that affects women that takes long to conceive.
So there is that predisposition, yes.
Okay.
We usually make this this joke that if you don't let your womb be occupied by a baby, then the fibroid will occupy the womb.
Okay.
Because it's just it's a predisposition, yes. Because pregnancy, throughout the journey of pregnancy, you are kind of cutting off the active hormones that will make whatever small risk that you have for growth of fibroids. During pregnancy, remember, even after pregnancy, you'll be breastfeeding. So physiologically, you're cutting off those hormones.
Yeah.
So, but if you don't, then you might be exposing you might be exposing yourself to the risk of getting fibroids.
Okay.
Yeah.
Okay, so I posted this laparoscopy on my socials, and then the lady commented and said that she feels pain on her shoulder after the surgery.
Okay.
Does it have side effects?
She had laparoscopy?
Yes.
Okay.
And then she says that after the surgery, she felt pain on her shoulder. Yes, experiencing heaviness and pain on her shoulder. Does it have effects?
Yeah, every form of management, whether it's medication, whether it's surgery, has a good side and a bad side, or let me say, an upside and a downside. Let me not say bad and upside and bad side and downside. Okay, so pain that you experience after surgery, you may get a bit of infection. Okay, it might take longer for you to resume your full function depending on what you do. Sometimes you may need to transfuse you with blood. Sometimes you may have small unexpected injuries, okay? But that one you get appropriately counseled by your doctor. But if you compare laparoscopy with open surgery, then we already know the amount of pain after surgery is less for laparoscopy than open surgery.
Okay.
Because
Okay.
it's minimal tissue damage, really. Okay. If you have a big cut across the 6 or 7 layers of your abdomen, compared to if I make a 5 millimeter incision, then you can see the difference. Okay. So pain, yes. After surgery, there is expected pain, but we're able to control that kind of issue after surgery with painkillers.
So how long will it take for someone that has undergone this procedure to go back to their normal life?
So every person is different.
Uh-huh.
Every person is different, depending on your age, your physical fitness or activity, the work that you do. Right? Generally, after surgery, we'll let you rest home for 2 weeks. Then we'll review after 2 weeks to assess your feeding, your bowel and urinary habits, how well you are able to go about your normal duties. Of course, mild duties, you have not gone to your exertions. Then we can give you more time depending on how you are. So there are those ones that pick up very fast, but generally we see after 2 weeks, then after a month from that time, you should be able to do your mild to moderate activities. If it's a major surgery, 2-3 months you should be up and running.
And someone that has undergone this procedure and okay, the person conceives and now she wants to deliver through C-section. Now that that incision was done under the lower abdomen, is it possible or during the C-section, the incision will be done at a different side? Yeah.
Okay. We prefer to use the same incision.
Okay.
Yeah, we prefer to use the same incision. You have less scars on your body. It's the single scar. We'll always go through that scar. Okay?
Okay.
So after each surgery, then your wound, your body reacts during healing. Of course, it causes a bit of fibrosis through the layers of the abdomen. But we can't create many scars. There are people who have done 4-6 surgeries. You can imagine if we are going through every time we are creating a different scar, it will not be aesthetically appealing. So we try to go through the same scar, close up the wound from there so that you only have one scar. Okay? Not 6 scars to remind you of your 6 surgeries.
Okay.
But also we have ladies these days who opt for cesarean section because of their pelvic floor health. Maybe that is something that you have also encountered. Okay, because childbirth and pregnancy is a risk factor for your pelvic laxity, for your pelvic prolapse, in future, for incontinence of urine, incontinence of stool, maybe sexual dysfunction. Okay, so but that's a discussion maybe if your viewers are willing to have, we can have.
Okay.
Yeah.
Okay. Now, before we come to an end, a close of our show, because time is not on our side, maybe you can just tell our viewers maybe something, a parting shot, or something that you want our viewers to know more about pelvic health, something that we've not covered.
All right.
Yeah.
Yeah, so pelvic health is one of my pet subjects. And as I said, pelvic health for a woman is critical.
Yeah.
Okay, God made us to have chambers within our bodies. So there's a bony hood over your lungs and your heart. There's also a bony hood over your reproductive organs. And between your between your chest and your abdomen, there's a diaphragm. Okay? And between your abdomen and your pelvis, there's nothing much.
Okay.
But there's a diaphragm down there to prevent those organs from coming through the vagina, because the woman has 3 outlets on her lower side. The man has 2 outlets, okay? But the vaginal outlet is where things can come through. Or they can also come through the rectum, yes, but mainly through the vaginal outlet. So God gave us the pelvic floor to contain those organs, to support our pelvis and our erect up posture, Okay? To be able to hold our contents from the bladder, that's the urine, to be able to hold our contents from the rectum, that's the feces and flatus, and also to be able to have a sphincteric action around the vagina also.
Okay.
So it will give us support, stability, sphincter function. Sometimes the contraction of the pelvic floor helps to pump out blood, of course, for health. But we also have risk factors that can make that flow not function well. Okay? So age is a natural factor. The more you age, your feminine hormones, mainly estrogen, will reduce. So the health of your tissues generally, especially around your reproductive, genital and urinary system, become a bit wanting. Also, patients who smoke, patients who had a family history because of some genetic tissue issues, patients who chronically are increasing their pressure inside the abdomen, those ones who are constipated, so when you're going to the washroom, you have to push all the time, okay? Because you're supposed to go to the washroom, relax your pelvic floor, and let the stool come, or let the urine come. But if your pelvic, either you have poor dietary habits or you have pelvic floor dysfunction, when you're supposed to relax, it's tightening, okay? Then you're going to have issues. You're going to really force. Every time you're forcing, you're weakening your pelvic floor.
Oh, yeah.
Those ones that are coughing throughout, especially our mothers in the rural areas, they use firewood, so they're always having these chest problems, they're coughing.
Okay.
Coughing increases pressure to the pelvic floor, okay? Those ones that are overweight, we always encourage our clients to reduce their weight, okay? Pregnancy and childbirth. Pregnancy and childbirth. So if you go through pregnancy and vaginal birth, then there's a risk of injuring your pelvic floor, okay?
Okay.
Either tear, or either the muscle separates, or either stretch from the ligaments. Ligaments are like tissues that hold things together, maybe bone to muscle, bone to some facial layer. Then there's a chance of injury, okay? After your first birth, up to a quarter of our women will have some injury to the pelvic floor, okay? These injuries, of course, if you keep having multiple births later on in your later years, then you have a risk of that floor giving up function, okay? And you remember the functions I outlined.
Yeah.
So you may have issues with your urine, feces containing sexual function and all that, okay? Pelvic health is important. How you prepare yourself when you're pregnant with your doctor, you have to learn relaxation techniques, you have to learn how to massage your perineum and your birth channel. During birth, you must have smart birth positions. Your healthcare workers know, they know when to maybe cut you, they know when to use some devices to extract the baby. How to repair is important. If you have a poorly repaired perineal floor or perineum, then there's an issue. You have to you find some women, they can't contain loose stool, they can't contain gas. Their husbands are complaining of some laxity, so we can refashion that. Or they can't hold their urine when it's really pressing.
Fistula?
Not really fistula, just fistula means the urine is coming through the vagina. Fistula, you have no control completely.
Okay.
Or the feces are coming through your vagina. No control, you'll just see it.
Okay.
But that one is quite unfortunate and extreme. If your baby is stuck in your pelvic tissues, your tissues are soft, right? But your pelvis is a bone. So if your baby is stuck there, the baby's head is also bone. So if the bone is fighting with bone, the soft tissues in between have to give way. Okay, so that's where you get abnormal communication from the bladder to the vagina, or from the rectum to the vagina. Okay? So basically, going through pregnancy, childbirth, and after pregnancy, okay? So after pregnancy, there is some exercises, some form of rehabilitation that you will go through, but because I said you will have some small micro traumas or major traumas depending on your birth, the weight of your baby, your birth size versus the size of the baby, So you'll have those, you'll need some rehabilitation after birth.
Okay.
You'll find some women also immediately after childbirth, they're into heavy lifting, they have gone to the gym. We try to discourage that. Okay, go through the rehabilitation. Your body will go back to the pre-pregnancy state. Then maybe you can resume your heavy lifting and all that. Because you run the risk of disrupting your pelvic floor.
Okay.
Yeah.
Okay. Now, where do our viewers find you? Maybe if you can share with us your social media accounts. Maybe someone is watching and is having the same problem that we've been talking about, and this person wants to reach you. Yes.
So here in Kakamega, right?
Yeah.
Okay. So SEK Church House, I have a clinic there, private clinic. Maybe you wanted me to read the number?
Yeah, it's okay.
The booking number. I don't have it on my head, but they can contact Mary. Mary is our clinic nurse. The number is 0768 104 597. 0768 104 597.
Okay.
Yeah. Those viewers maybe from Kisumu, I can also book them through Mary. And I also have some clients in Nairobi. I can book them through Mary.
The social media accounts?
Oh, which one is Facebook? Or?
Yes.
No, I don't have my medical. That is just my personal account.
Okay.
But maybe one of your staff advised me to open a TikTok yesterday. So yes,
You should, by the way.
Account.
Yes, you should.
You have one?
A TikTok account?
For your program?
Yes.
Maybe they know. You can tell them yours.
It's the Hope Circle. Also, we have another one for Afya Yetu program.
Hope Circle.
Yeah, Hope Circle, it focuses on PWDs.
Okay.
Yes. But now this one is health. We have another one for Afya Yetu.
So maybe they tried to set out a TikTok yesterday. Maybe, is this one? You can read them there. MD Urogynecology 2.
Okay, okay.
Maybe we set up yesterday, TikTok.
Okay, just the name itself. I can't pronounce. Maybe you can just say it for. Yes, I will tag it.
Then we can share with them.
Okay.
Yeah. All right.
So thank you so much for joining us.
Thank you.
Thank you so much for sharing with us.
Yeah.
I know my ladies here, they have learned. They've learned a lot, more to do with the pelvic health and also their health and hygiene.
True.
Yes.
Yeah. Those are really big subjects.
Hey.
Maybe it was just your focus points, but they're really big topics. We can't discuss them in a day.
Okay.
Yeah.
Okay. So thank you so much, guys, for watching. I've been your host, Charity Inyanya, and we meet again to our next episode. Of Afya Yetu.
Thank you.